So I wanted to tell you about this unusual, unique case of one of my patients, Jay Fukazawa, whom I've met for the first time when he was hospitalized in, I think it was 2018, for blocked bowel. So that was his presenting symptom. He actually started having hiccups, vomiting. There was no knowledge at that time that he had cancer.
So I was like 54 at the time, and having stomach problems, like pains, digestive issues, and then I just couldn't eat after a while. Unfortunately, I just waited. I just kind of held off. I kind of just never went to, I tried to avoid hospitals. I always felt healthy, never had any problems. So I ended up choosing coming here, St. John's, because I always passed by the building and it was always so present. You see it. There's other major hospitals too, such as UCLA and Cedars-Sinai, but I just chose this.
On further evaluation, when he was admitted to the hospital, there was evidence of a large kidney tumor in the right kidney.
We got scans and there was cancer in the liver, in the lungs, in the bowel, in the bone. He had cancer everywhere. And I remember him going into the OR. I remember them removing the tumor and thinking, wow, I was not sure how this patient was going to do, how Jay was going to do long term.
I was given the news that they had found, they had seen several masses, such as a 18 centimeter tumor on my right kidney, and there was a mass in my small bowel, which was a 4 centimeter mass, numerous lesions in my lungs, and that there was it had spread to my left rib.
So he required surgery, abdominal surgery, to remove that blocked segment of the small bowel of the intestine. What was found inside the small bowel was kidney cancer metastasis that was blocking that segment of the bowel. So that was the first order to surgically remove that segment of bowel, relieve the obstruction. And he recovered from surgery quite well, but then we had to deal with an underlying issue, which was metastatic kidney cancer from the large kidney mass, and as I mentioned before, spread to lungs, lymph nodes, and also there was a bone here, the chest bone, the sternum that was involved. What turned out, when microscopic analysis of that segment of the bowel that had cancer in it was consistent with kidney cancer origin, but it was not a typical kidney cancer, which the most common type of kidney cancer is called clear cell carcinoma, but it was not one of those. Our experts, pathologists, really had a hard time pinpointing exact subtype of kidney cancer. So it was ultimately called unclassified. So this is one of those rare kidney cancer variants that doesn't quite fit into a specific category. And frankly, those are usually not good. They don't have a favorable behavior. They usually are very aggressive and difficult to treat.
When I heard the news, to be honest, I was never really shocked about it. Be told I had cancer because I was feeling so bad. I had a feeling it was worse than I had expected. I almost had planned that for this bad news because of what I was feeling. And I had chronic coughing. It just didn't stop. I met Dr. Twardowski, and then he started talking about, treatment. And then he talked about a clinical trial and that I seemed like a pretty good candidate. Met the whole team with the research nurse, the coordinator, and all kinds of people, a nutritionist, the social workers. It was such a great team.
So because of that, and also because of emergence at that time of evidence that immunotherapy treatments may be beneficial in metastatic kidney cancer, we offered Jay participation in the clinical trial, which had a core treatment of two drugs that are relatively commonly now used for advanced kidney cancer. One is called nivolumab, or Opdivo is the trade name, or ipilimumab, Yervoy is the trade name. So that combination formed the core of this clinical trial. However, there was also a random assignment on top of that to possible incorporation of the experimental drug in the pill form called epacadostat. So there was the theory that that drug, that experimental drug, may amplify or improve the effectiveness of the immunotherapy. So Jay agreed to participate in this trial, and he was assigned to the experimental arm that had 3 components. Again, the nivolumab or Opdivo, ipilimumab or Yervoy, and addition of that third drug in the pill form called epacadostat. So he started treatment, and slowly but surely, essentially everything started shrinking over time. I don't remember exactly the timeline, but over several months, he had bulging tumor kind of in the bone here in the chest that started melting away and disappearing. So it was even visually noticeable that things were getting better, and these were confirmed on subsequent scans that were performed regularly. Both his kidney mass was shrinking, all of these metastatic sites, almost all of them were going away.
And I remember my very happy surprise when Dr. Twardowski, who was the medical oncologist, said, "Well, are you ready to take out Jay's kidney?" And I said, "What?" I said, isn't he on systemic therapy? Doesn't he have cancer in his bones and his lungs and in his bowels? And he's like, "Yeah, that's all gone." Because remarkably enough, a lot of these patients on systemic therapy, the primary tumor, for whatever reason, doesn't really shrink away. It might die, but it doesn't go away. And so obviously you don't want it to come back, which is why you then take out the kidney or the tumor. But I mean, Jay is a remarkable story. He had minimal side effects. He did great with the treatments. I mean, this was a person whose, to say it very plainly, body was riddled with cancer from his kidney and somehow overcame all of that.
The funniest thing, I considered a real wonderful time. I think one of the things people would like to know is that that St. John's really provides care management is quite wonderful, to the degree that they take care of you at every level, the attention they spend, and just the sheer kindness. The one thing about St. John's is their clinical trials, and I don't know if anyone's really aware of that. It's something happening in your own backyard, practically. Some of the most life-saving therapies in the world.
What happened, though, that along the way, over the next couple of years when he was on this trial, there were a couple of minor setbacks. So one was that while everything was shrinking, there were a couple of areas that we saw enlarging lymph nodes. And one was in the, I think, left armpit, if I remember. And initially we thought maybe it was just a kind of inflammatory response that sometimes you can see with immunotherapy, where the lymph nodes that have cancer, they kind of swell up before they start shrinking, but they kept enlarging a little bit. And because that was the only area that wasn't getting better, slightly getting worse, we decided to just go after that surgically. And Dr. Trevon Fisher, who's an expert here in lymph node surgery, excellent cancer surgeon, performed the dissection or removal of these lymph nodes that in fact did harbor, again, metastatic kidney cancer. But that surgery essentially removed that area of that kind of troublesome area that was not responding well to the drug therapy. And then, he was doing quite well, again, continued on drug therapy. And then we were faced with the decision because, things were getting better and better, but there was still this large kidney mass that was shrinking but didn't completely go away from view. So because we really didn't see any significant remaining tumor or cancer evidence in his body outside of this kidney area, we asked our kidney surgeon specialist, Dr. Linehan, to also go surgically after that kidney and remove it. And indeed, she did that, and Jay tolerated the surgery very well.
What could have gone wrong is that the cancers could have, all the different areas where the cancer were, from the bone to the lungs to the bowel, could have responded to different treatments, which in some ways did happen a little bit, but they were responsive in the end. That is not always the case. A lot of times after they're on the treatment, the cancer can recur relatively fast, which also didn't happen, even though it clearly was very biologically aggressive because it went all over his body. And I think, with the surgery, we were suspecting that he could have had a tumor thrombus, which was cancer that goes into the biggest vein in his body called the vena cava. We were a little suspicious of that, but he didn't actually end up having that. But he had these very enlarged lymph nodes that were around his kidney, around his large vessels that we ended up having to take out. And so doing surgery in that area of the body around the biggest vessels can be quite dangerous, because if you end up injuring one of those vessels, it's a lot to fix, may need a lot of blood transfusions. But really, given all the treatment that he had and the amount of cancer that he had, his surgery went very well. We did take out the lymph nodes, we took out the tumor, and he did great.
But after that, we have not seen any evidence of any persistent or recurrent cancer in Jay. We've scanned him, repetitively. He's had probably, I don't know how many, 30 scans over his journey of cancer treatment, and nothing came back. There was no evidence of cancer. So we finally, after roughly, he was on these drug therapies for 4 years, and 2 of that was on the clinical trial, and then the clinical trial finished after 2 years, and then we just kept him on that core 2-drug regimen of nivolumab and ipilimumab. And at some point, because these drugs are usually well tolerated, and Jay did amazingly well in terms of ability to function normally and live relatively normal life on these drugs, we decided that in view of complete absence of any visible cancer, that we're going to stop everything and keep our fingers crossed and just monitor him very carefully. And that's what we've been doing, since I think August or September, when he stopped all therapy, and scans continue to be completely clear. So he's considered in complete remission, no visible evidence of cancer. It's still not, I wouldn't call him necessarily cured yet, because that's a pretty high bar. We have to give it more time of follow-up and see over the next couple of years to make sure that that's maintained, that the remission is maintained, before we can be more and more confident that he is indeed cured. So it's a quite remarkable story. On so many levels, very unusual, extremely aggressive cancer, unusual presentation, kind of with blocked bowel. It's not commonly seen. Exceptionally good response to modern immune therapy. There was this experimental drug component that who knows whether it had some impact on the degree and depth of the response that he had. And also example of really extremely helpful multidisciplinary approach, when you had our surgical colleagues essentially helping us with the areas of cancer we couldn't completely eradicate with drug therapy. So they would provide vital help in that collaborative approach that we took, and incorporation of modern immune drug therapy led to this remarkable outcome that we've had with Jay.
For me, coming here was just a joy, if I could say that, because it's obviously one of the worst things that could happen to anybody. I love my doctors. I think they're the best. Come to St. John's, talk to the doctors. I think the treatments and clinical trials are leading edge, and the environment and the care team is just wonderful.
So he's just an incredible story. And incredible response to systemic therapy and working with Dr. Twardowski and trying different treatments and staying engaged in his treatment, which I think sometimes is very hard for patients to do, especially when it's prolonged. You know, a lot of times patients will get chemotherapy and they're going to get it only for like 4 or 6 weeks, and there's there's an end to what they're going to get. But this was just prolonged treatment until we could get the tumors to all resolve and then finally take out the kidney, and he's done so well after that. I mean, he really is an incredible survival story.
We are definitely witnessing significant improvements in outcomes of patients with kidney cancer, but most of the advances, I would argue, have been proven in these patients with more common variant of kidney cancer called clear cell carcinoma, which Jay didn't have. He had more unusual subtype. As I mentioned, it was difficult to even put specific name to it or classify it. And we did, very sophisticated genetic analysis of the tumor, and it didn't quite provide any particular insight into that. So yes, we can cure some patients with metastatic kidney cancer, particularly clear cell cancer, maybe somewhere in the 5 to 10%. That's still a very low number, but quite remarkable that even that can be accomplished these days in patients with sometimes widespread cancer throughout the body can achieve these durable remissions that can essentially equal cure. And it's not a common scenario to have this kind of dramatic response that he had. There's so much science, but there's so much uncertainty on a daily basis when we deal with patients, and we really cannot predict in an individual patient what's going to happen. But yes, Jay was, he's an amazing patient. He's been always extremely optimistic and focused, very compliant with everything that we recommended, and he's just an amazing individual. And I think his attitude, it's hard obviously to quantify it, but I do think it helps that his trust in what we're doing, his belief in science and participating in clinical trial, benefit himself, but also hopefully benefit the science doing that is quite amazing and inspiring.
For me, it saved my life. It's a place of healing, of care. I think anyone, if you should find yourself in that position, I would tell you, come to St. John's.